quite an honor to be here today to give this talk to all of you, and thank you so much, and I welcome everyone for coming here today. So I'm going to talk a little bit about disparities in stroke. Let's see how this thing works here. So I have no commercial disclosure, but I was funded by 3 research grant agencies. Since this is the World Federation symposium or conference, that I wanted to talk a little bit about a global perspective of stroke. So as you know, in the United States, stroke has now become the 5th leading cause of death from used to be number 3 cause of death for a long time. But in Hawaii, it still is a 3rd leading cause of death. But if you look at worldwide, stroke is a number 2 leading cause of death, right behind ischemic heart disease. And even though we're doing a pretty good job of preventing death, stroke incidence is increasing in the low-income and middle-income countries. And the overall global burden of stroke is projected to be much higher in year 2020. And this is the graphical view of a leading cause of death in the world. You can see that number 1 is ischemic heart disease, and stroke is right behind the heart disease, and then down to COPD and so on. This is the global map of age standardized stroke incidence per population for 2010. The more red it gets, it's the higher number of incidents per population, and the more blue color you get, it's a low number. And you can see that countries such as Russia, China, Africa, Southeast Asia have very high incidence of stroke compared to places like Australia, New Zealand, and South America, and Central America. And you can see here that America is not leading in terms of having a low stroke incidence. It's somewhere in the middle. This is a global map of change in the stroke incidence from 1990 to 2010. So over the 20-year period, the countries that had increase in the stroke incidence is coded in more red color, whereas the countries that did a pretty good job of preventing stroke from happening with prevention strategies are colored in blue. So countries such as Europe, Australia, New Zealand, and even South America like Brazil and so on have done a very good job of reducing the number of stroke incidents, much better than the United States. And again, Russia, China, Africa, and so India are having more and more stroke incidents. But if you look at the mortality rate, we're the best. We're very good at the tertiary care, ICU, TPA, mechanical thrombectomy, so on, and we can really prevent death from occurring after the stroke. Other countries that we mentioned, such as Australia, New Zealand, and Europe, are also good as well. And the reason why we're very good at reducing death from after the stroke, actually, I'm sorry, this is the figure. This is the bar graph showing that the stroke mortality is very high in Russia, Nigeria, and African countries, and India, and China, but much less in UK, Canada. Unfortunately, this figure didn't have US, but it's right next to Canada and UK. We can do this because we have such, all the tertiary emergency protocols such as ENLS, neuro ICU where I work, neuro interventional where we can get the clot out and so on. So we can actually get people through and have them live, but live with disability, but perhaps poor quality of life. And I'm not sure if that's the solution for what we need to do globally. So in summary, for the global burden of stroke, stroke mortality have definitely gone down, but the overall burden of stroke have increased, and the major burden is still in the low and middle income countries. And there have been increase in stroke among young and middle-aged adults, especially aged between 20 and 64 over the past 2 decades. So what about America? I'm sure you have seen this kind of map where it's called a stroke belt, where the stroke incidence is very high in the southeast region. I kind of joke around saying it's the SEC conference for the football. All that area is very high, and also high in the northwest region as well. And the stroke incidence and stroke mortality is much lower in the northeast, sort of what I call the Ivy League region, in Stanford region maybe. But if you look at the stroke center location, it's really clustered in that what I call the Ivy League or the Stanford region, and much less in that Southeast Conference region. So there's actually a disparities in the accessibility of the primary stroke center. So why do we have so many stroke centers in a place where we don't have, well, I wouldn't say we don't have, but we have less of stroke incidents and not so much in the area where we actually need a stroke center. And that's actually part of the problem that we have. What about racial ethnic disparities in acute stroke care? So here are some of the facts, I guess. So blacks have 35% higher stroke mortality compared to whites. Blacks are 50% less likely to receive ITPA compared to whites. Only 11% of black patients get a neurological consult or neurological care compared to more than 20% of white patients with stroke get a neurology consult. Blacks were 50% less likely to be sent for any carotid imaging, which again, Dr. Salem said it's very important to do that kind of workup for the stroke prevention. And blacks were 50% less likely to receive cerebral angiography. And these are some sad facts. What about risk factors and incidence? So again, blacks have much higher risk factor of hypertension, diabetes. And even after you adjust for cardiovascular risk factors and age and so on, their risk of having a stroke is much higher compared to whites, especially among the young population between age 35 to 44. And then in the multivariable model, the lower socioeconomic status seems to be driving some of these high stroke incidents. And in terms of annual stroke incidents per capita, blacks have about 753 stroke incidents compared to 424 among whites in the same 100,000 patient population. So that's almost double the incidence. And there are a lot of lines here, so these are different lines means different multivariable models, so I don't want to really go into that. Just know the trend of this sort of a line, meaning that this is the hazard ratio of comparing the risk of having a stroke, comparing blacks to whites. And basically what it says is that when you go to the older age, like age 70 and above, there's actually not much difference between blacks and whites in terms of their stroke risk after you adjust for cardiovascular risk factors. So if you're age 70, the chance of this patient having a stroke in 1 year is pretty much identical compared to this person. But when you go to the younger age, so younger than 1650, this discrepancy is increased. So even if you account for absence or presence of diabetes or hypertension or obesity and age and gender and whatnot, if you go younger, blacks have much higher chance of having a stroke. So if you think about it, how does that happen? If you take away all the risk factors and everything, if you normalize everything, why would one race have higher incidence of stroke at young age? It's puzzling, right? I'll get to that in a minute, but I can show you that the blacks and Hispanics have much higher incidence of hypertension and diabetes compared to whites, but not so much for AFib. And if you look at the stroke subtypes, I think Dr. Salem mentioned all the different subtypes. So large vessel disease, so carotid disease, embolic stroke, small vessel lacunar stroke, and cardioembolic such as AFib-related stroke and cryptogenic stroke. The distribution or the portfolio of the stroke subtype is different between blacks and whites. So blacks have much higher incidence of small vessel disease or lacunar stroke from wear and tear from hypertension, diabetes, much more so than something like AFib or cardioembolic stroke, and also carotid disease. This is a study looking at outcome between the two races. And it basically showed that white patients have much higher chance of achieving good, favorable functional outcome after stroke compared to African American patients, and those were statistically significant. What about what happens after stroke, so the rehab process? There have been many studies, and there have been a meta-analysis that showed that blacks are less likely to achieve equivalent functional improvement following rehab compared to whites. And improvement after 3 days of physical therapy and rehab seen in only 16% of blacks compared to 35% of whites with stroke, and that was statistically significant. And the mechanism of this is unclear because physiologically you think that if you have the exact same stroke, then they should both do the same. So what's happening in Hawaii? So again, we're going from global perspective to the United States and here in Hawaii. So I'm going to focus on hemorrhagic stroke or intracerebral hemorrhage. As all of you know, ICH is a devastating hemorrhagic stroke that accounts for about 15% of all strokes, and it occurs from the spontaneous rupture of the small arterioles. Forms a hematoma, which can cause mechanical damage to the surrounding brain tissue, and about 70% of them are due to hypertension. And when I came here in 2010, I was shocked to see so many young people with a hemorrhagic stroke. I was used to seeing people in their 60s and 70s, even anything 50s with hemorrhagic stroke on the mainland where I trained. And I was looking around and saw so many people in their 20s and 30s with a ICH. And they tended to be Native Hawaiians or Pacific Islanders. And this is one of the examples of a 27-year-old Native Hawaiian who had a left basal ganglia hemorrhage, all from uncontrolled early onset hypertension. And his outcome was devastating at 3 months. He was very disabled and couldn't walk, couldn't be independent. And when I looked around and then did a PubMed search of racial ethnic disparities in ICH in 2010, I found some papers showing this disparity in the age of onset among Hispanic Americans, African American, and some Maori in New Zealand, but I didn't see anything on Native Hawaiians here. So the first step that we did was that, so we did not know anything about Native Hawaiians and Pacific Islanders with a ischemic and hemorrhagic stroke at the time. So our first step was to do a retrospective study of data from 2004 to 2010 at this Queens Medical Center and show that Native Hawaiian Pacific Islanders, which is abbreviated as NHPI, was much younger than the non-NHPI. So you can see this bell-shaped curve shifted more to the left, that the mean age is around clustering around 50s in the Native Hawaiian Pacific Islanders compared to 60s and 70s in the non-Native Hawaiian Pacific Islanders. And this is a busy slide, but it showed that on Native Hawaiian Pacific Islanders, the mean age of onset was around 55 compared to Asians being 67 and whites being 66. And Native Hawaiian Pacific Islanders had much higher prevalence of diabetes, hypertension, increased length of stay, and actually lower mortality, probably due for young age. We were able to publish this result in 2012, and we were able to go from this state in 2010 where we had no knowledge of Native Hawaiians to this. We were able to add our data into the scientific literature and also showing that our population has much younger age of onset even compared to blacks and Hispanics on the mainland. The limitation of our study was that we did not have a methamphetamine data in our database. And just to let you know that in Hawaii, we do have a lot of a problem with the methamphetamine abuse in our community, especially among our minority population and low socioeconomic people. And the argument that one can make is that, maybe the young age of ICH that you're seeing is not because of this cardiovascular health disparities, but because they're just using a lot of meth. Okay, so that was one criticism. So trying to address that, I'm sorry. So this is an animal model of a methamphetamine, when you give methamphetamine in mice, like every day, they all have hemorrhagic stroke. And this is a collaborator from Nebraska who told me that. He said that I give meth on mice every day, and after certain days, they die. I open up the skull, they all have hemorrhage. and meth causes damage to the arteries, causes high blood pressure, it's toxic to the brain, and it causes inflammation. So really, our next step was, what's driving this age disparity? Is it meth, or is it really from cardiovascular risk factors? And how much of this was due to a lack of blood pressure control? So we started a prospective cohort study in 2011, funded by AHA and NIH, and really followed people over time. And in 2014, when we analyzed the data, we had about 200 patients. We were able to demonstrate again that the Native Hawaiian and other Pacific Islanders age of onset was around like mid-50s compared to the mid-60s in the whites and Asians, which we published before, validating what we saw before. We also saw that our population had much lower income class, low income class. Not that many people are seeing the PCP, much higher rate of hypertension and diabetes. And here's the main result, is that in Hawaii, about 24% of the ICH among Native Hawaiian and Pacific Islanders, at least in our cohort, were due to methamphetamine abuse, compared to 0% in whites and 12% in Asians. When you compare the meth-related ICH and non-meth ICH, the meth ICH were definitely much younger, confirming that a lot of the young ICH is due to meth abusers. But even if you take out the meth ICH and only look at the non-meth hemorrhagic stroke, we're able to show that Native Hawaiian Pacific Islanders were still having an age of onset less than 55 years old, confirming this health disparities that we see. That's what we concluded and published in 2015. So, what is really driving this age disparity, even if you take out the meth factor? When we did a multivariable analysis, we did show that one of the main driving factors was a lack of a regular PCP visit, which had the most robust odds ratio of almost 5. So 5-fold increase in having early, young ICH if you're not seeing a PCP regularly. And this is the impact. So if you look at only the hypertensive hemorrhage, so like basal ganglion hemorrhage and so on, the group that had actually PCP was seeing regularly, like once a year, the mean age of onset was in the 70s compared to when they didn't have PCP, they were having hemorrhagic stroke before age 55. So this is like a 17-year difference. And if this was a cancer trial, this is like a most robust difference. So in cancer treatment, chemotherapy, if you can extend life by 5 years, that's like awesome. But here we're talking about if you have a PCP, I'm saying that you're not going to have a stroke for 17 years. That's really robust. Another question that we asked was, is there any kind of a racial difference in functional outcome after ICH? So, after a stroke, there are a lot of things that need to happen, physical therapy, occupational therapy, speech therapy, and a lot of support after that with the family and so on. And there are a lot of post-stroke depression that occurs, and you need a lot of family support and friend support. And we hypothesized that perhaps due to all these intangible factors, one ethnic group may have a better outcome than the other. So again, we have the ranking scale, 0 being no symptoms at all, to 1 and 2 being mild disability, 3 and 4 being moderate to severe disability, 5 being really bedridden, severe disability, and 6 being dead. We usually draw a line between 2 and 3 to define what's favorable outcome. So no symptoms or just a mild disability is considered a pretty good outcome in the stroke literature. And we have shown in our cohort that, surprisingly, Asians had the lowest number of favorable outcome after ICH. And this was after accounting for age, ICH score, so severity score, hematoma size, GCS, all those things that you may want to criticize, saying that maybe they just had a worse ICH. So even if you account for severity in age and gender, Asian race was negatively associated with a good outcome. And I'm not really sure why that's happening. The more I looked into the literature, there are actually other genetic factors, polymorphism, that actually predict functional outcomes. So there may be that component as well. So here's a graph of a distribution of the ranking scale. So far left is 0, and then far right is 6 dead. So you can see from a mild disability to severe disability on that side. And you can see that yellow dashed line of where I draw the favorable functional outcome. And you can see the Asian group had the much lower percentage of people who achieved good outcome at 3 months. So moving on to ischemic stroke. So we did a similar retrospective study looking at a much larger number, close to 2,000 patients, to look at the health disparities. Again, similarly, we saw that Native Hawaiian Pacific Islanders were having ischemic stroke more than a decade younger compared to Asians and whites here. Again, the age of onset for ischemic stroke was 60 in Native Hawaiian Pacific Islanders compared to age over 70 for the other group. And not surprisingly, they had much higher prevalence of hypertension, diabetes, dyslipidemia, obesity, and as well as higher LDL, lower HDL, and much higher BMI. And we published that in 2013. So we kind of knew this, right? Minorities have worse health outcome and incidence and so on. So really the question for us, or responsibility for us, is how are we going to address this? It's not easy, okay? So, we have to really acknowledge the complex nature of this dynamic social medical problem. It's not like we can just go around the community and say, hey, get with the program, start exercising, eat healthy, know the fast, stroke symptoms, and call 911. It's not like that. These are the people who have 2 jobs just to stay afloat, and between their 2 jobs, they only have $5 cash in their pocket, and they can just only stop by McDonald's, pick up a combo meal, and then have to do meth, not to have fun, but just to stay go back to the night shift work at night. These are the people, a lot of our patients take or do meth just to have two jobs, actually, not to have fun. So, and it's very complicated, and it's not easy to just say get a PCP and go see the PCP, because they can't take the day off to go see the PCP. So it's very complicated. And we have to really understand the role of stress. I don't think we talk about this whole lot in the hospital setting, the function and the role of psychological stress on cardiovascular health. So that's why I wanted to touch on today. And then at the end, I want to go over the modifiable risk factors. And you may think that you know the risk factors, but hopefully I can shed some light in terms of the importance of a certain one. So going back to the really old, I have 5 minutes left? Okay. I'll go really fast, but this is an interesting one. So Whitehall study is the most interesting study that I think. This was done in the 60s in England, 18,000 male civil servants, okay? So these are all male, so no gender factor, pretty much all Caucasian, so no race factor. They're all civil servants, so they all had health care, health insurance, they all had PCP, and they're all government workers, so the pay difference was not like, comparing CEO to the janitor. I mean, it's like, there was some differences, but not huge, okay? And then basically, the people in the lowest grade of the sort of a job hierarchy had a much worse mortality rate compared to the highest grade one. And this is the figure. So the other group is like the messenger, housekeeper, and so on. Manual labor people had way higher mortality rate compared to professionals and managers and so on. And this is even accounting for smoking factor and whatnot, okay? And then there's a lot of things that we know about stress that we don't talk about. Cortisol changes a lot in your body and makes you higher risk for metabolic syndrome. And as you know, metabolic syndrome can cause all sorts of cardiovascular badness and cause a stroke and heart attack. And for the sake of time, I'm going to go through really fast because KJ is looking at me probably. Hurry up. So just really fast, one study showed that just the perception of jobs insecurity was associated with the poor health, okay? And among black patients, those who experienced unfair treatment and racial discrimination at work had much higher carotid plaque thickness than those who didn't. There was a randomized trial that basically did a meditation, okay, among hypertensive blacks and showed there was a significant decrease in the carotid plaque thickness compared to the control just by meditating for like 6 to 9 months, okay? Actual measurable carotid plaque. There was another trial that did a meditation among black men and women with a coronary heart disease, and then the intervention group got the meditation frequently. I forgot the frequency or intensity, and the other group just got a health education. And then this was a positive trial that showed that those who were getting steady meditation had almost a 50% risk reduction in the primary endpoint, which is like stroke, MI, and death. It's huge, okay, just by meditating. So risk factors in 2 minutes, okay? This was just published in 2016, and we've known that 90% of the stroke burdens now attributed to modifiable risk factors, okay? 90%, so pretty much stroke is now a disease because of our lifestyle. And this color shows you how much of the modified risk factors is contributing to the stroke in that country. So like Russia and China, like 95% of that is due to modifiable risk factors compared to somewhere like Canada and then US, it's much less so. Okay, and then what we found recently is that air pollution accounts for about 1/3 of the stroke globally, especially like in China. And these are some of the risk factors that we talk about maybe in the prime PCP setting. And then I want you to just conceptualize and put some weight or points to each one, saying what's most important, because it's hard to address all of them in one visit, right? So you got to pick your battle. So you got to conceptualize what's most important in terms of stroke prevention. And here's the visual representation. High blood pressure is like 10 times more important than talking about your LDL, stop smoking, and exercising. I mean, they're all important, but this is it. You gotta control the blood pressure. It's way more important than talking about Lipitor and whatnot. I'm not saying to minimize Lipitor, but this is the linear relationship of the stroke incidence of both hemorrhagic stroke and ischemic stroke. So every 10 point your systolic blood pressure goes up, your risk almost double. So if your systolic is 160 or so on, your risk of having a stroke is like 5-fold compared to if your systolic is 130. That's huge. Okay, that's way more like high impact than talking about Plavix or aspirin and whatnot. And if your systolic is the 120 compared to systolic being 130, again, 10-point difference, your stroke risk goes down by half. Okay. Same thing for diastolic blood pressure. It's amazing. Okay. So there's no excuse for having our patients walk around with a systolic of 140 or 160 or 150. That's just not acceptable in my mind. In outpatient world. And then based on that study, they did a calculation that hypothetically, globally, if you were to lower blood pressure of everyone on this planet by 5 millimeter mercury diastolic, so let's just say hypothetically, like we just dispense ACE inhibitor, ACE thiazide or something, everyone to take and drop their blood pressure by 5 points, we can eliminate almost a third of the stroke from even happening. Okay, that's like really. Yeah, but we're not doing it. We're talking about mechanical thrombectomy. We're talking about TPA. We're talking all, which is important, but we need to talk about this as well before discharge. Okay, KJ, I'm done after this. Okay, so this is what was published from 2016. This is like eye-opening. So this is, we now know that, high blood pressure is by far the #1 risk factor for stroke. But, if you look at the global column, number 2 most important risk factor for stroke is not eating enough fruits in your diet, which is more important than smoking or a high sodium diet or low vegetable intake, way worse than cholesterol and whatnot. So not eating enough fruits, okay? So that's eye-opening, right? So I eat a lot more fruits now. And if you look at the high-income North America, fruit is number 3, but still very important. And number 2 is the high BMI. So now, again, you got to consider people with diabetes and so on, but you really want to encourage your patients to eat fruits, berries and so on. So that's all I have.